All right, 2 hours. Don't fall asleep. I'm going to be covering many years, 3 decades of the HIV epidemic, and so we're going to go through a lot of history. So for the first part, I'd like to be able to dedicate to those professionals and those who dedicated their lives to eradicating this disease and had the courage to march on when there appeared to be no hope in sight. I'm going to begin with a story. It was 8 o'clock on a brisk Monday morning when a call came for me to see a woman by the name of Maria. She had been depressed all weekend, and the nurses felt unable to get through to her. When I entered Maria's room, wearing a required mask and gown, she immediately looked the other way. I introduced myself. I told her I'd heard that she had been feeling very sad. I also told her that I was there to listen, and anything we talked about would and could stay between us. I quickly learned that I had been one of many people who had flowed in and out of Maria's room, asking her questions. And the questions they asked were all the same. They wanted to talk about her recreational drug use and the details of her sexual practices, and to think back and to talk about all of her previous partners, including their names and addresses. The questions never seemed to end. With all the questions asked, no one asked about Maria, about who she was, her likes, her dislikes, accomplishments. No one asked what it was like to be alone in a hospital room, battling one mysterious infection after another, incontinent and frightened. And nobody asked about the most important person in her life, her 9-year-old daughter, whose whereabouts were unknown and who would be left orphaned and alone. As the weeks went by and the questions continued, Maria felt increasingly guilty, unwanted, dirty, victimized, overpowered, and isolated. When I met Maria, she was clinically depressed and dying. Like most relationships with people who are living with HIV, what was then not known to be HIV, our relationship was intimate, intense, and very short. I was able to find Maria's daughter, but by that time Maria was intubated. Her daughter had a chance to tell her mom how much she loved her and how much she would miss her. And when her daughter cried, "But Mommy, I don't want you to die," I saw Maria's first tear roll down her cheek, and she was able to write, "I love you too." Maria died from a mysterious illness. It was cruel. It was painful. It was unrelenting. It was February 7, 1982. Later that year, there were an increasing number of previously healthy, vibrant gay men who were being admitted to hospitals both on the East and West Coast, down in Florida, with swollen lymph nodes that were known as lymphadenopathy. And I do have a sheet that describes many of the terms I'm going to be using. A rare pneumonia known as pneumocystis carinii, disfiguring skin lesions known as Kaposi sarcoma, unrelenting diarrhea, which cultured out to be cryptosporidium, chronic fevers and weight loss, which is known as Macrobacterium avium, and mental status changes, which are later to be known as dementia or encephalopathy. I was called to provide consultation to the chief of the dermatology branch at the time, who was seeing an increasing number of these men, and he was a specialist in classical Kaposi sarcoma. He felt that these men had significant psychopathology, and he needed a social worker or a psychologist to come and to be able to help him with this clinic. My background in private practice was predominantly in the Upper West Side, the theater district. I was very comfortable in the gay community. I was psychiatrically trained. If any of you know NYU's program, it was a very psychoanalytic program, though that wasn't what I was practicing at the time. And it was so clear just from the very beginning that these men had vibrant personalities and lives, productive lives, prior to becoming sick. So it was the beginning thinking maybe something organic was going on. But at the time, there were terms being thrown out. There's a new gay disease, gay plague, GRID, known as gay-related immune deficiency. Later, the term AIDS was proposed. Classic, what you would see in the newspapers from 1883, mysterious, lethal disease. So I was given the task of developing a psychosocial support program for this new growing population, which was called the gay-related immune deficiency population, and began by going and saying, well, what do you need? What are the needs of this population? First thing, to be able to assess from them what is it that would make this a little bit easier. So we had routine, systematic quick questionnaires, just looking at the kind of services they would be able to use, and we learned that they really needed information, really wanted to be able to have support, and were feeling very isolated. Also, there seems to be a lot of depression, and we used an anxiety and depression scale, which showed that they were significantly higher than norms. Not surprising when people had something mysterious, unknown, uncertain going on. And we also, as it seemed to be sexually transmitted, had a measure of interest to see if they were interested in sexual risk reduction guidelines. And what we found is that 58% did not indicate a risk in looking for risk reduction guidelines, and it was those groups, those individuals who were depressed, were the ones who were not asking. Well, we can imagine the public health consequences and who you would want to be able to target, but this was presented at the very first International Conference on AIDS, so I know I'm dating myself. So we had to be able to then think about how to provide support, and we started many different kinds of support groups. The KS, Kaposi Sarcoma. We had in the support sessions, which would be every 3 weeks, and then we have a speaker on the 4th week. There's a lot of self-disclosure. We talked about concerns, different ways that people cope with their changing health status. And in the education parts, we had people from the Gay Men's Health Crisis. I think if you read in The Band Plays On, I may be dating myself as well, Larry Kramer. Many of the people we read about would come and talk about services, what was happening, and to be able to help people to become advocates on their own, both locally as well as nationally. So the group was fascinating. The person who recommended the group died soon after the group started. So it was the collective force, the tie to this particular group was so incredibly strong that they stood together for many years and reached out to each other, but we had many challenges. One patient had a seizure in the middle of the group, another one committed suicide where another group member found that patient, and many, many goodbyes. But the group didn't end. They would refer the people, they would come back. It was their home, it was a sense of identity, and it was a place to be able to learn. Other groups we had was a lymphadenopathy group. We don't even call it that anymore, but it was, people who had swollen lymph nodes, not knowing, again, that there was a virus, but that they thought they may have a mild version of what was going on. Couples groups, because if somebody's partner was that concerned, they would also become symptomatic. Bereavement groups, as you could again imagine, were dealing with the mourning, the grief, unresolved legal issues when partners weren't allowed to be able to have legal rights or be able to visit, monitoring one's own health. Are they at risk themselves? Staff. At the time, people would say to the providers, why are you doing this? Aren't you at risk? I don't want you to be able to do this. Are you going to come home and give this to the rest of us? A lot of thoughts. But as all of this was going on, there were new scientific breakthroughs as well. A retrovirus that kills the T cells from the lymph system was identified, first in a gay man, then in a hemophiliac. This retrovirus would be then go through different names as well, HCV3, LAV, before it being named what we know as HIV. And then there were reports of AIDS amongst women with no other risk factors, suggesting heterosexual transmission. In one of my couples groups at the time, there was a man and a woman that were there, and it was most of the groups were just partners being both men. And they talked about a club that they go to that was an open sex club that they went to and the partners they were with. And I remember just the people looking at each other and saying, if this disease is transmitted sexually, can it be between men and women? And it was one of those days, that you left and just say, this is really just the tip of the iceberg. But it was around this time that the pediatric story was also unfolding. In December of 1982, a 20-month-old child received multiple transfusions of blood, died from infections related to what was then known from the virus to be AIDS. There was clear evidence that it was caused by an infectious agent. This also caused additional concerns about the safety of the blood supply. And a few months later, the CDC reported the first case of possible mother-to-child transmission, suggesting, and I put down quite incorrectly, of the possibility of casual household transmission. Typical at the time, you would see, a whole methadone clinic. This is 87% are carrying the antibody. So people are talking about from drug use and needles, and then whole families, and this was hemophiliacs who then became or were infected. When it came to children, tremendous fear and stigma. In the United States, here, it was feared that even drinking from a communion cup would transmit AIDS. If you remember the story of Ryan White, or anyone who gets funded still through Ryan White funding, the 13-year-old hemophiliac was barred from school. And I'm going to ask you to see which president this was, who was asked, would you send your child to school with the child who is known to have AIDS? And this president said, it is true that some medical sources had said that this cannot be communicated in any way other than the ones we already know, and which would not involve the child being in the school. And yet medicine has not come forth unequivocally and said, this we know for a fact, that it is safe. And until they do, I think we just have to do the best we can with this problem. I can understand both sides of it. Bingo. Around this time, 3 hemophiliac boys were barred from school. The family fought and won a long federal court battle that allowed them to attend public school despite their diagnosis. Their home was burned down a week after the decision. January 1986, New York, my home. I left, down 95. You like that? I didn't have to find something positive about leaving New York to come to the NIH, where I began working at the National Institutes of Health in one of the 26 institutes known as the National Cancer Institute. And so from this point on, I'm going to be talking about the NIH pediatric experience. So I came to help, as Dean has so eloquently stated, I came to be able to help incorporate pediatric HIV into the existing pediatric oncology program. This was no easy feat. The staff, they weren't interested in incorporating pediatric HIV into the pediatric oncology program. They trained to work with kids with cancer. The doctors who were there trained to work with kids with doctors. And if the staff is going to be comfortable, how do you think the parents of a child with cancer is going to be when their child's roommate has AIDS and their child is already immunocompromised? So the first year was really spent making sure they had all the education they can. And when you're dealing with resistance and all your organizational people, you really want to go with the outside experts because the inside experts are never believed. And so we had to get to the point of saturation where they said, all right, bring the first patient in already. I can't listen to any more education. And we did. And it actually worked beautiful. And the kids would share rooms, toys, bathrooms, and many of them became very close. And between December of '86 and October of 2005, we had 550 children living with HIV enrolled in many different clinical trials. And because of those, AZT, DDI, 3TC, some of the protease inhibitors became available to the public because of the trials that we did, and we worked ourselves out of a job. And the families came from all over the country, and the states, the stars, are the only states that we did not have referrals from. So to say we had a cross-sectional population. And I saw my role there really is to begin to document what was happening from a psychosocial research perspective by listening to the children's voices, their writings, their artwork, and the voices of the families and the clinicians. But the research had to be able to be organized in a way, and so I organized it around 3 different areas. The first, as we talked about before, was needs assessments, to assess the needs for practical and emotional assistance and to see how that changes over time. The second, which is the bulk of the studies, is to investigate the psychological and social experience of the children and families, how they cope and how they adapt. And then to take both what we learn from the needs assessment and from the coping studies to formulate a program and design interventions that addressed the needs and the problems. You guys able to hear me okay? Too fast? Told you that New York comes right back. So the program was really based on doing what we consider in the biological field anyway to be translational research, the clinical services, which are pretty classic clinical services and the research agenda, and really what we have is back and forth. So what I would hear clinically, I would design a study for, what I learned from the study to put back into the program. So what was the very first study we did? So the very first is to compare the needs, because I didn't know what the needs of parents of children with AIDS was. And so we compared them to the needs of parents, to families of children living with other chronic illnesses. And we looked at both cancer and cystic fibrosis. And what we found is that the parents of children diagnosed with AIDS had a higher expressed needs for information, mental health services, and community resources. There really was no significant difference in anxiety or depression, though the AIDS group was tended to be higher on both measures. The parents of children diagnosed with AIDS showed significantly higher levels of social isolation and feelings of stigmatization. And all of the parents asked for a telephone network. I put that out there, a way to be able to connect with others. Now, this is a time when families would be sitting in a waiting room, and if somebody said the word AZT, they would be like, I can't believe I heard that, and their ears would go out to be able to see there's someone else who's actually talking about this. So we knew that we needed to do innovative approaches for support because people in the home communities wouldn't even access, if there were services, because they didn't want to be seen as going into an AIDS clinic or into a program of being identified. So all the families, we asked them if they would be willing to talk to a new family who was coming to our program. And as a new family was coming, and we had a 6-month waiting period to go into trials at the time. Remember, AZT wasn't even available. So we would connect them to another family who has a child around the same age. And one family would call the other. I'd be on the phone together, I'd introduce them, I'd hang up, let them talk. And it would be the first time they've actually talked to another family and be able to share that experience, which also made it a lot less frightening traveling across the country and coming to us. That was so successful that we then developed telephone support groups. And we had 8 different telephone support groups for parents who were infected and non-infected, both moms and dads separately. We had grandparents, foster parents, adoptive parents. We had for siblings, non-infected siblings, and for the children. We tried with the boys, didn't work. And the grandfathers was a little, and considering that I had to go through all the transcriptions, 8 weeks, when something is not working, you learn your best lessons from what doesn't work. So we were able to record and transcribe. We looked at the organization, the format, the content, and then really were able to show a protocol that this really is a very good technique to be able to use for people living in rural areas. This doesn't have to be just for HIV. And by the way, on the corners are where these things are published, so if you want to read the articles, they're there. So the needs assessments, we continue to do them every 3 years. And so just to show you how things may change over time, and when the program was the largest, really over time, people had less need for information as more information was available. The support groups, this isn't an accurate number because we had the Children's Inn did open up and families would talk to all hours of the night. So where before they wanted a support group once a week, then twice a week, then 3 times a week, and then the Inn opened and they didn't really need it because they were talking all the time anyway to each other and found each other. But what I'll draw your attention to really is the counseling because that had continued to increase as the child got older. A theme hopefully you'll walk away from. The older the child, the more issues there were. So part B, the coping and adaptation studies. Again, longitudinally, let's follow people over time and to be able to see about how things change. And here's a listing of through the years how one study blended into another. And I'm going to be talking about several of these. But they really did, what you learn from one is very easy then to be able to apply that to the next study. So we really are talking their voices. It's what we hear from the children and their families is what we then able to apply. So let's look at the first study. That was looking at parent coping, and that was from 89 to 91. We had 101 parents, and we looked at, again, their coping and their anxiety, and some depression and anticipatory grief and health status. And most of the studies had a mixed methodology, meaning that I had the quantitative but also a qualitative piece. Really believe the qualitative is probably the richer of the material. And at the very first start, we found that the age of the child, the diagnosis, the older the child was at diagnosis, how the disease was acquired, and how frequently the child was having infections correlated with greater distress. So let me just show you a little bit on a graph. So at the time, we thought of the disease differently. So people didn't start on a treatment until they got to a level where they were having major infections and hospitalizations. So the people and the second time point where they really were having the most anxiety, they knew their child was changing. They were no longer asymptomatic. They were having more frequent infections, but they weren't sick enough to get anything for it yet. And so that lowered once they were actually, you would think, but they're sicker now, they're in the hospital, but they actually were doing something. You felt less helpless. Also, the age of diagnosis, which is clear. The older the child was when they found out, the more anxiety there was. Longitudinally, when we looked at that later, the current age of the child was still significant. How old the child was at the diagnosis was also still significant. But the child's medical status, the caregiver's relationship, how the disease was acquired were no longer significant. The parents really liked some of the questionnaires. In fact, some of them asked me, those coping questions, they really spoke to me. Can I get a copy? That's pretty unusual to do. But then they said to me, but what about our children's coping and how they adapt? Because they're getting older and they're asking a lot of questions now. And we need to know how they're doing and what we could be able to do with them. And at the time, there was a lot of stigma. This is around the time when I showed you some of those slides before of what was happening to families. It's a good thing in Washington you're yesterday's news really quick because you were, but what I'm showing you this for is because what was in this article was that here I was hugging a child with AIDS. And you see it, hugs a child and smiles with a child with AIDS. How amazing that could be to the front page of the Washington Post. But there was a lot of issues that were going on. We knew that there were CNS complications. Children were losing developmental milestones. We knew that there was something we called encephalopathy, where there'd be atrophy. The neuropsychologists were studying that, but we also seemed to be, along with that, psychiatric manifestation. So the next study, which was a longitudinal study, to look at what the frequency of psychiatric disturbances were, and we had kids between the ages of 6 and 11 at 3 different time points. Does anyone here ever use a scale called the Dominic? No, it's one of my favorites. It's a Canadian scale, and it's pictures. So let's say you're looking at the different dimensions in the DSM, and you have depression. The child may be looking down, and tears are coming from his eyes in the picture. It's Dominique. So with the tears coming down, and all the child's friends are outside playing, having a good time, having the time of their life. So you go through all the items that you would ask on a CDI, one of the standardized tests, but they're all in pictures. And for that, the kids would engage. Do you feel like Dominic, or do you not? To that to give versus when you ask them a question, yes, no, yes, no, how many more? It was well validated with the standardized measures, but I really feel like you're getting accurate information. And what we saw is anxiety and depression increased over time, which underscored we really need to monitor. That the parental perception of the disturbances in the child was higher than the child really reported, so the parents were very concerned. But there was also a strong correlation between how depressed the parent was. So the more depressed the parent was, the more they saw their child is having problems, and that's been found consistently through different diseases as well. But the issues were disclosure. They're getting older. Do I tell my child? Do I not tell my child? My doctor says I have to tell my child. I don't want to tell my child. I'm afraid my child knows. I don't think my child knows. But there were no studies then to know, well, what are the factors associated with the parent's decision to disclose or not disclose the diagnosis? What are the factors associated with the parent's decision to disclose their own status to their children, the ones who are infected or not infected? And so we developed a study, and the third arm was to examine the emotional reactions of public disclosure. At the time, we had about 18 children who were very public. And when I mean public, I'm not talking about they told their friends. I mean, they went from Jesse, Sally, Raphael to Phil Donahue to the different talk shows. And we had a lot of kids in clinic who says, can I have an AIDS like he has? They really felt there was something very different about themselves. And so it was of interest to me to be able to get a sense of this group and to see what was going on. But clinically, I wanted to get information about when and how the diagnosis should be communicated to the child. That's the qualitative piece. So we had 99 parent-child pairs, and what we found is that the children who were disclosed to tended to be older. The parents who had been disclosed to their children were less depressed. The parents who had disclosed had more satisfied with their support network. Well, they had people they could talk to. And the non-disclosed children came from lower SES families and tended to be HIV positive themselves. We obviously were not able to interview the kids who hadn't been told their diagnosis about how they feel about not knowing the diagnosis, but we were able to interview the children who did know, and so the qualitative piece gave us a lot of information. First, after a parent struggled for about 2 years before they shared the diagnosis. From the time they thought my child's old enough, I need to be able to tell him or her, it was a good 2 years before they were able to do so. 45% of the children said they really weren't surprised. At lunch, I shared a story that was just amazing to me. I have this poster in my office that said, I have AIDS, please hug me. And in a session, one child pointed to it and they said, that's what I have, but don't tell Mommy, she's not ready to know. It's like, wow. But parent intuition really needs to be respected, as 65% of the children felt they were told at the right time and by the right person. The ones who didn't feel like they were told by the right person, who do you think they were told by? Can't hear. Where they came from? The doctors. Please, guys, take that message home. If you can't hear something from your own parents, what's the message to the child? Even if you want to do it with the doctor and the parent present, but have the parent present so they're part of the process. So 30% of the respondents felt that life became more difficult after disclosure occurred, even though there were many positive things that take place. And these findings ended up being part of what created the policy statement for the Academy of Pediatrics on disclosure of illness to children and adolescents with HIV infection. What about the public disclosure? About a third of them said it was their parents' decision to go public. When asked if given the chance would they go public again, 83% of them and 80% of the children said they would. However, 61% of the children and 47% of the parents reported wishing that they could go back just to be themselves. You know, I just want to be Johnny. I don't want to be Johnny with AIDS all the time. You know, so when guiding people in terms of having a public life, you can't take it back. It's important to be able to look at timing and reasons why somebody would want to be able to do this. Also because in elementary school and middle school, they're comfortable. By high school, many of them felt like they wish that they had not gone public. Also, the children who were public had significantly lower global self-confidence than children who are not public. The caveat here is that I didn't have baseline, so I don't know what their self-confidence levels were before they went public. They could be a lot better now. But when a child tells me their best friend is Janet Jackson, it's a little concerning. What about the clinical implications? When you withhold the diagnosis, the child suspects they're more seriously ill than they've been told. Parents are sitting on the phone or whispering or leaving the room when the phone rings. Families are often burdened by a lack of candor in their own house because they just feel like they have to hush-hush about certain things. Often there's another child in the home who may know, is told not to tell. So that burden of having to be able to lie in a family and to hold that information. If there's two parents, one may feel like the child should know, somebody may feel like they shouldn't, and there could be conflict there. And trust. The trust is jeopardized because when the child does find out, it often is a sense of, you know, what else haven't you told me? So when should the child be told? Well, this really requires knowing an individual, tailor-made approach that has to be gradual, that looks at the child's cognitive abilities, coping abilities, how the family communicates, the caregiver's own mental health. If they're at a place where they're feeling very overwhelmed, this is new to them, the mom just found out she's infected and feeling very guilty and very tearful, it's not the time to portray this information to the child. The family, understanding their cultural beliefs, what's comfortable, how they communicate other information. The kind of stresses. If a child is under tremendous stress at the time, this isn't a good time to add another one. Look, what's priorities? For some, really, they need a home. You know, the diagnosis of HIV is really low on our totem pole here because I don't even know I'm going to get my next meal. So again, to be where they're at and to look at the priorities. And other losses. How much is this child and the family lost? Are there other secrets? Have other people died of the disease? Are there other people infected? So that you would have to be able to disclose the other losses or the other issues first before you can get to this. But pave the road. Pave the road so that they have some information on which to build later. Starting young. To be able to use whatever words you are using, and then you can go back at a later point and say, do you remember when I told you? And if they change medicines, do you remember when I told you? And you could add a little bit more. And you could add the titles and the letters, because the titles and the letters are going to mean nothing. They'll mean something on an intellectual basis. It's really just going to be letters until they're in a hospital. Or because of this, they have to take new medicines. Or because of this, they lost some friends. Or because of this, they lost somebody else or a friend or somebody else who's living with the disease. The other part is that just because you have this conversation doesn't mean it's over. Some people say, well, I told them I never want to talk about it again. It takes a while to be able to absorb that. And we also have to be able to communicate to the child that no matter how difficult, come back and we can talk about this anytime. So we have our ABCs to answer specific questions, to be where the child is at, and to allow silence if necessary, but to create an accepting environment. So, what do we see clinically after a child learns their HIV diagnosis, learns that they have HIV? There's a huge range. Some may be shocked, some frightened, some sad, some confused. We may see a delayed reaction, like, okay, but then have an acute anxiety reaction later. Some may have psychosomatic complaints, many. I don't care about that, but they're headachy, their belly hurts, they're coming home from school. They may have nightmares versus night terrors. They may have nightmares. A lot of lability. They could have regressive behavior. There's somebody, parent that I remember just saying, they're sucking their thumb again. There's just those type of regressive, self-soothing, comforting behaviors. You can see an adult-like acceptance. This is what I have, and they'll repeat like a book of virology to you of all the words that they've had, but how much is integrated. But there's often a lot of pride when they feel like they understand what's going on and have words at least to put down to make some sense of what's going on. I love this because the child may just say, yeah, I'm fine, and they come in the room in complete knots, and so is the family. And so once a child has been told their diagnosis, I have a range of different modalities that I use. One, nothing happens without a relationship. You need to have a therapeutic relationship. But I'll use artwork, letter writing, sentence completion, workbooks, and poetry. And I'm going to address each of these pretty quickly. But the first thing I'll do is say, if HIV has a face, what would the face look like? An example. This, obviously, I was very concerned for a person who feels I have the devil within themselves. Then I'll say, draw a person who's infected and a person who's not. Again, I'm giving you some more extreme examples because you know where your work is cut out for. I'm going to be talking more about mandalas because I do a lot with them, but here's an example of someone who was not told. They were 13 years old, and they were getting an x-ray and opened up their medical chart. He was sitting with his mom, who was infected, and his younger brother, who was also infected, and that's the way he felt. He found out, and mom just said, I don't want him to know, I don't want him to know. The father had died, and they never told the children why their dad had died. And the most right in the center, it was, I'm just embarrassed. Like, duh, 2 + 1. I mean, like, how many people know, and I didn't figure this out? How many years? It's been coming to us for 6 years. How many years have I been coming here, and all these people know, and I don't? Mortified, embarrassed, angry at mom for doing that. And, of course, the color background says a lot, too. On the other hand, is one who says for a child who was not infected in the family, is imitating the mother. Your sister and I have HIV. How did you know that Dawn and I had it before I told you? So the other extreme. In 1988, we were very respectful for new families would come in and they would say, I don't want my child to know their diagnosis. We would respect that because I knew that we would be working with them. It would be a process over time. But the one thing we wouldn't do is lie. So don't ask us to say you have a different disease than the child has. We won't engage in that. And this morning I was seeing a little girl who, in a session, and before I was going, the new family was coming in from far away. And this new family was adamant, my child's not to know. So in the session with this little girl, she told this horrific story about how she sneezed and boogers came out of her nose and her teacher sprayed her with bleach. But she was playing and telling the whole story in a very playful kind of way, but it was obviously a traumatic experience, and I needed to go meet this other family. So I went out to the waiting room, and I said, we'll talk about this more later, and I went out to the waiting room, and I introduced myself to this new family. I said, hello, I'm Lori Weiner, and as I did, somebody knocked me on the back of my back, just like this, and I turned around, and it was the little girl who was just in the session, and she had a Fisher-Price microphone. And she said, hello, my name is April O'Neil, and I'm from Channel 6 News, and I'd like to know how you would feel if you had the HIV virus. And my first thought was just like, here's this family which I promised we weren't going to be able to do this to. And I was just like, so I walked away, and I just said, I think it would be pretty hard. What do you think it would be like for you? And she walks away from me. She goes over to her mom. She sticks the Fisher-Price microphone in her mom's face, and she said, Mom, how would it feel if you had a daughter with the HIV virus? And I said to myself, wow, if I could only get this on tape. So we had a little video camera, and I had interviewed her, just talking to her mom later. And I went to my boss at the time, who was Phil Pizzo, and I said, could I just get money to be able to film her interviewing whoever comes to clinic the next time she does? Because let her just talk and interview the kids. We'll learn from the kids that way. So that's what happened. We may want to turn the lights a little bit.
How do you feel about the enzyme? Well, I don't feel good about it because you get it when you start like a little baby, like I started it. It doesn't feel good because when you get shots every day and every morning, it doesn't feel good.
Which he's not.
Then, they have to take more, and it's really hard with the medication. You have to take a lot of pills and medication. I go to the hospital. I go to the hospital. I need a friend. I need a friend. I have egg. I have egg. I have egg. Where the best are the ones that like you, and the ones that aren't the best are the ones that they don't want to play with you and they run away from you. What do you think about stigma and counseling? Well, I think that we should find a cure for it that we're trying to do so everybody will be well and we won't have to come here or any hospital unless we're really sick. We are really sick, and it matters that kids are alive. It doesn't matter about candy or stuff. It matters about the people here.
This is a time, if you look between 1990 and especially 2000, we lost over 200 kids. And if you can imagine the situation for the children who were there and getting very close to the other children and playing in the playroom together, as hard as it is for us as adults, what the experience is for them, especially after they've been disclosed to. At the time, parents really struggled about how aggressively they should be able to provide care for their children. And here you could see a very aggressive scenario. For them, what their work was to be able to say, how aggressive should I be? When should I let go? When will I know it's okay to be able to let go? Will I have the courage to be able to let go? And for many, they did find a way. For this particular mom, it was saying, okay, I'm going to give 3 weeks of this antibiotic to work on the vent, and if it's not working, then I want him to be able to just to take him off, and I want to take him and just bag him. We're going to go under his favorite tree so he could listen to his favorite birds and die in my arms, and that's what we did. But a sense of, let me be able to give it every chance I have that I didn't leave any stones unturned. But at this time, I have to say, I was spending probably about a quarter of my days on the phone with bereaved parents. You know, and the common comment would be, and it makes perfect sense, I know that people need to go on helping the living, but what about me? You were such a part of my life. Everyone was such a part of my life every single day for so long. So I took the model of the telephone support groups and did monthly groups with bereaved moms. So we were able to get through the first birthday, the first anniversary, the first Christmas, you know, different holidays and different events together. And it was very useful for them. And one of the quotes that I put in here is, I could never have imagined anything lonelier than losing my daughter. I felt empty, raped, with no reason to keep on living. The group made me have a sense of belonging, and it made me feel needed and understood again. I don't know how long each of us may be on this earth, but we need to make the most of each day we have. We have a reason to live. We owe that to our kids, and we now owe that to each other. So how do you capture that in some data as well? So we had a bereavement study that looked at the differences in bereavement reactions in parents who lost their child to cancer versus AIDS, and I'm just putting the AIDS piece in there. And we looked at, you know, symptomatic distress with the LCL-90, looked at perception of support, if they were able to talk to the child about what was going on, if they had talked about DNR, if they had an autopsy, if that was helpful, and the prevalence of evocative experiences. Raise your hand if you know or don't know, if you don't know what an evocative experience is. So there's one person. It's an unusual occurrence where you may sense the smell, the vision, hear the voice of somebody who is gone. And one of our nurses who was training to be a chaplain suggested we put that question in. And really, that was about the only thing that I ended up publishing from this study. We had, I think it was like 83% sent letters. Thank you for asking this. I can't talk to anyone about this because they think I'm crazy. That Thanksgiving I come in roses. My son we always had roses on Thanksgiving, and the house smells from roses, or a voice, or things that really actually were very comforting. So we found that the biological fathers are actually scored higher on depression, different time points that were difficult. Open communication was essential, and multiple losses. This is a family disease. We can't lose track of the fact that this is a family disease. I had a cute little girl who came to my office, but her mom wanted to sit down and talk first. And her mom talked about how tired she was. She was just exhausted, and she just didn't know how much longer she's going to be able to take care of her children. She had 3 older children and this little girl. The long and short was that her husband had left them. He had moved away to another state. He found another woman. The woman had a baby. Soon after the woman had a baby, the woman died. He didn't know anything, but came back to his wife and said, "Can you please take me back with this baby?" And the the mom said yes, and she loved this baby just like it was her own, but little did she or he know that he was HIV infected now and gave it to her, and she was losing her sight from CMV retinitis. And this is the little girl from that other union. And when Mom left, we talked about certain things, but being cautious. Although the girl knew the words HIV, I said to her, she goes, I don't like it. I said, you don't like what? I don't like HIV. And I said, you want to write a letter? Yes. Tell me what you would say. Dear HIV. And so I wrote it down. I don't like you. Because of you, my mom is sick. That makes me feel sad. Because of you, my dad is sick. That makes me feel very sad. Because of you, my mom and dad could die. That makes me feel very bad and very sad. I could cry and cry and cry. Because of you, my brothers and sisters are worried all the time about what's going to happen to our family. That is no good. So, HIV, listen to me. I don't like you at all. Go away. Leave us alone. We just want to live without you. Do you have any Barbies? Typical kid. So, as the years went on, she lost her mom at 10. She lost her dad at 13, and she herself died at 17. This is a family disease, and we're going back to the time of the epidemic when so many of the treatments we know now were not available. But the message that her mom says is, will I be remembered? Will they know how much I love them? Do they know that I didn't do this to do any harm to them? And how do we give them a voice to know that they're going to be remembered? So we developed many different kinds of techniques and different things. We do art. For this mom, we wrote individual letters to each of her children, and finally she was able to do one at the end for her husband, and she asked me to find the time that I thought was ready for them to have, and I still hear from them, and they often can't find it or it got old and want another copy of it. But we also began doing videotapes. It's a living legacy, which is where I met Susan Taylor Brown, and she and I actually have done many of them together and studied this together. So the message is what I want my children to know and to always remember, and it's not for everyone, and it shouldn't be done when somebody is very sick. It takes preparation, but I'm going to show you one example of videotape.
There are 9 children in our family, and Shaquana's mother was my next to the youngest sister. And her name was Dorothy. Dorothy was 33, and she passed away in January 26th. And so now we have her blessed one, Shaquana. Obviously, Dorothy had a hard time accepting the fact that she was HIV positive, and obviously that she was going to die. And so later, 3 beautiful as a group, there's a hospice society in Albany, and they have been very, very helpful. And they've worked with us individually. They've worked with us as a group. They've started working with the children. So yeah, counseling is very important. You need to get it out. You need to be able to verbalize. You need to be able to show the anger. You need to be able to show the hurt. So it definitely is a help. It definitely is a help. And videos like the one that you worked with Dorothy, it's just priceless. There's no other way to say it. It's just absolutely priceless.
You guys okay? Well, to a more positive right now is because then protease inhibitors came about and the epidemic began to change. And with better treatment options, which, what was once viewed as something that could be a relentless and progressive fatal disease, began to be seen as a chronic illness. But new challenges emerged, especially as the children were getting older. First, many who were not expected to survive, parents didn't think school was very important, so they weren't academically, or they may not have had very many limits placed on them or much discipline, so they weren't emotionally prepared for adolescence and young adulthood. So we thought it would be important to be able to look at the factors associated with survival. And we looked at those with 13 to 24 to be able to look at adjustment, disclosure, support, and their quality of life. And we found social support to be critical, no surprise, and those who had more support with people who had lower problem behaviors, and also when people are able to disclose and had people in their life who knew what was going on, it was also seemed to have less behavior problems in adolescence. And in one study, for the year after the child had told their friends, their CD4 count increased. So that was pretty remarkable. But if you look at some of the life events that were taking place in these kids' lives at this point, this is when they were average 16 and a half years old, 55% already experienced a life-threatening medical event of their own. So when we look now at the trauma models and people, things that they have witnessed and seen as they were getting older and still living with a sense of uncertainty, you can imagine some of the challenges you have in front of you. Many people felt lost between a parent and a close friend. Some felt they were too far behind and dropped out of school. And these were relatively healthy kids. And those who lost a parent were significantly more likely to be able to use drugs or alcohol, be sexually active, and to have suffered from depression and anxiety. So early maternal loss in the melancholy picture. And we asked them, what are your greatest challenges today? And for them, it was disclosing the diagnosis to friends. Again, the disclosing, taking all the medicines at the right time, worrying whether I'll die from the disease, getting along with family members, and then the last one was keeping up with all the medical appointments. No association was found between the age of learning the diagnosis and later psychological distress. So people say, is there an age they should be told so they'll do better later? There was no correlation between that. So it was around this time that I was asked to give a keynote on children growing up. In the epidemic. It was 15 years after the epidemic, and the talk was from the National Social Work and AIDS Conference. It was out in LA, and that happened to be in the same weekend as the Pediatric AIDS Foundation picnic. And remember the tape I showed you of those 3 little kids before? Well, 2 of them were going to be out there. So I said, how cool would it be if, I showed the tape and let them tell what it's like. And I showed the tape, when the lights came on, they could be sitting there. So I was able to get funding for the 3rd. Oops, whoa. I was able to get funding for the 3rd, and so if we're running out of time, I'll cut it short.
And now this medical report. Children with AIDS are living longer, according to a report released today by the Society for Behavioral Pediatrics. Young people infected with HIV virus are now living well into their teens, defying earlier predictions that they would die young.
As you see here, I have 3 very special friends to introduce to you.
And I tried to get the first down and they didn't care who knew. So they put the rub out on us and they're like, we don't care who knows. Like if you have a pint, that's supposed to matter, so we're not going anywhere. And I know that by going out to speak and stuff, I can stand up in front of people, and I know a lot of my friends that just choke. They're like, people? Oh, that doesn't mix. No. But I'll go out there and I'll talk to anybody. I'll just talk to just about anybody. Except when I first started, I wasn't very strong, but I learned.
I am who I am now. I'm not afraid. Back then, I was afraid to tell people of who I am, what I have. Now, I don't care. I'll tell you who I am, what I have, what do I do. Don't matter. Maybe a strong person. I was on a basketball team, though, back in 8th grade, and one whole team got dissolved because they found out that I was infected with AIDS. I didn't know. And they should have
had to hold on for that one because it was just worth it. So there you had 3 people who were able to be public, who had a lot of the luxury of being able to know a lot of people. And, is this really what representative of the rest of the population? And it is not. It was representative for them and their experience. And we looked 5 years later at the group, and what we have found, and you could look over here between 13 and 17 and 18 and older, in some areas it looks like the kids are doing a little bit better in terms of anxiety and depression, but there's still significant anxiety depression. There's still a significant amount of suicide ideation, and there were a few pregnancies and arrests. So we really had a population who was growing up not expecting to be able to survive, didn't know what the future is going to bring, lost many people in the family, maybe between different foster homes, still a sense of uncertainty, and what do we be able to do with that? So we realized that we had now a population over the age of 18 who are chronologically ready for independent life, but not emotionally so. And the major issues that continue to need to be addressed were disclosure, dealing with the grieving, the multiple losses, anxiety and depression, being sexually active, making sure they have risk reduction guidelines and they're practicing safer sex behavior, and then adherence, major problem. So one thing we did is we looked at what is the prevalence of these kids even being on psychotropic drugs, medications. And again, we had, if you saw from the original slide, we had families from all over the country. And so this was just a single institution, but again, it was a representative of patients from all over. And it was a really high, 45% at this time were reported to be on psychostimulants and antidepressants being most commonly prescribed. 30% were on 2 or more. In terms of the sexual behavior, there were many kids I would talk to, and they didn't seem to have, despite the fact how many times I've talked to them, they really seemed to still not get it, which made me have a real difficult time sleep at night, especially as they're getting older. So we looked at 40 of the HIV-positive adolescents, and we interviewed them at 2 different times. And we looked at, again, their safer sex knowledge, risk reduction behaviors, how if they felt they had the confidence to be able to say no or use a condom or be able to talk about their diagnosis, and looked at their Tanner stage, which is the stage of sexual development. And what we found is their HIV transmission or safer sex knowledge was low, but it did increase with age. And both self-efficacy for and actual condom use was high, which was reassuring. But by the time the participants reached full sexual maturity, which is considered Tanner 5, at least half reported being sexually active compared to the earliest stages of pubertal development, which means that when people look at this population at an age where, compared to their peers, then maybe not being sexually active, it takes them longer to be able to get through development. So the girls may start the periods at a later age. Puberty just is delayed. So don't stop your interventions just because they're older and you think that they are not being sexually active. And we also found no relationship between how sick they were, how high their viral load was, or low the CD4 counts were, and being sexually active. And one of the main reasons that people would be having high viral load is because they're not taking their meds. It gets old. So you look at this picture, and here's the Mandela again, and you have the medicine. It's the center of their life. It's really, I've been doing this for how many years? It's really old. I don't want to do it. It tastes disgusting. I'm not going to take it in front of other people. I just don't want to have to do this. And you can imagine the frustration for parents who've worked so hard to keep their kids well and to keep them here to get to this place, for them to just stop taking their medicine. So the treatment quandary is what I'm asking, something I could do myself. And at this point, when you see Haidia talking about 14 medicines, there were often a lot of medicines. You can imagine when parents are sitting saying, but I can't get them off to school. We fight every morning. Hurry up, take your meds and make the bus. If you face this every morning. So for those of you who remember To Kill a Mockingbird, think of the To Kill a Mockingbird reality test. Put your feet in their shoes, squish around a while you're comfortable, become them, then open your eyes and view the world from their perspective. Good old Harper Lee. It's not easy. How do we know if they're even taking it? How do you be able to look at if they're being adherent? So we looked at 3 different ways to measure adherence. Just self-report. We had telephone diary, where we called them 3 random times during the month to be able to see if they're taking their medicines, and we had nurse report. And we found that the viral load was highly correlated to individual reports of adherence, but none of these are terrific, tools to be able to do, though. Calling them at home was the most accurate of all of those. But we were able to look at the advantages and disadvantages. The bottom line out of all of this is there are barriers. There are barriers to taking your medicines, and if you don't address why you're not taking it, never mind all the fancy tools or your electronic monitoring or all the other stuff that may come out, if you don't really talk to the kids and understanding what are the barriers, why aren't they taking the meds, what has become so difficult, your most heroic and beautiful intervention is just not going to work. And unfortunately, for some kids, it is too late because they become resistant to all of the drugs that they're on. So how do you intervene? And bringing back into the clinical piece, jumping through hoops. We know that unless you speak to teens in their own words, and they'll tell you that, we won't get it. So it's the relationship. You have to find comfortable ways for them to be able to share. We talked a little bit, you heard a little bit about the game, which I'll be glad in the next session. I brought 20 copies for any of those people who are clinicians, if you could use this. The game is 10 different domains. There's 10 different stores to shop at, and it assesses different dimensions. But it's a really fun game to be able to play, and you learn a tremendous amount about your client and what they're going through, and a lot of opportunities for corrective emotional experience and to explore different coping mechanisms. So you could do it individually or as in a group setting. I do a lot, you saw the mandalas. It's a Jungian technique. I have them close their eyes. Let's say the theme in the session is, having to tell my friends. And I have them close their eyes and tell me everything that comes to mind with having to tell your friends. So they may just say, I'm frightened, rejection, whatever else comes to mind. And then when I have them open their eyes, I read them back to them, and I say, which one of these do you feel most powerfully? And let's say they say rejection. I said, the circle is you. Where in the circle do you feel this the most? And they just, they'll say all around the edge. And then I say, draw it, whatever it looks like to you. And then I'll say, what color does it feel like? So you can imagine that everyone's mandala is completely different based on their theme. And we studied this as well, and we're able to look at themes, and you see positive and negative things. It's a very powerful, very easy, and very inexpensive techniques, and the reference is here too. But let me show you some ways that it's come out really helpful. It's been really helpful clinically. A lot of times someone's saying, I'm fine, but they're having all these psychosomatic symptoms. So again, the belly aches, the headaches, not going to school, other stuff coming up. And so for me, just tell me about your life with HIV, close your eyes, and I'll get something like this. Oh, I'm just fine. Somebody else will say, I just have questions. That's it. I just have some questions. Well, what are some of your questions? When will I die? Will I live long enough to go to high school or college or get married? Will there be a cure? What's going to happen to me tomorrow? So getting older, it's more like you see a lot with the spiral, and I'm not an art therapist. I work really closely with the art therapists. It's again, a very non-threatening technique, and they're so proud of what they're able to put down on paper, which is really hard to be able to find words for. Anger, probably for the best when you're dealing with things like anger. Here's someone who had HIV and cancer. The middle was just rage, anger, and his parents were weighing him every day because he was just not gaining weight. And that little green line over there, that was fun. The intervention for the family is next week when you come back, that green is going to be a lot bigger for what's going on in your life, and get off the scale. And probably the most concerning one was this. My life has been happy and bright, but having AIDS is like a bullet in the head. Face of hope. Teen groups. Sometimes we'll draw a picture of a head and just say, what are all the thoughts going through your head? Name them. Put them down, and we write them in. This is a day in clinic, and there were a bunch of boys, and I just said, here's a word. Come up with a word. And they said, smile. I said, great, smile. Your S, your M, your I, your L, your E. Write something underneath that. And they did. So you have to just be creative. But again, it's giving them a voice where they're not going to sit in a session and say, oh, well, I'm feeling particularly vulnerable today, and I'm a little sick. It's just not going to happen. But you put them together. And another great one is people are going to say, no one's going to do poetry, and boys aren't going to do it. You'd be surprised. So we have poetry groups. It's with a poet and myself. And the poet will bring in some poems, but as soon as they come in, they say their name and they throw any word on the wall, and we write it down on paper on the wall. So maybe spaghetti, or stupid, or whatever the word is, and we put it on the wall. We'll read a poem together, and then after that, they have to pick a word from the poem. We throw that on the wall. also. And then we just talk for a while, and at the end we come up with a theme, just a name. So one time it was the 13th floor, another time it's just lying, whatever the theme may be. And you have to use all the words that are on the wall and put it into a poem. So here's one that I'm going to read to you because this one was just so eloquent. It was in yellow are the words that were on the wall. The swan of passion. The other swans laugh and call me names, for I have HIV. Inside me it hurts to see my friends laughing at me. I want to tell them to stop. I want to tell them it's okay. I want to tell them to see beyond the horizon. But they will not listen. They will not hear but their own voices. They think that they might get it just by floating by me. They think that they are better than I. They think that I am a threat to them, their well-being, and to all other swans. What they don't know is that I, too, can feel. I, too, can hurt. I, too, can heal. I, too, can fly. I hope that they never have names called upon them, and if they do, that they realize that wings can take you anywhere. Camps. There are different camp programs, and Sue could be able to talk about the ones that are up here, but sometimes they have teen retreats. Camp Heartland does, but they teach getting your first apartment, applying for disability, how to get insurance, how to go on an interview, and those are free of charge. Please look up Camp Heartland. It's called Heartland 1 right now. But it was important to also look at now what's going into adult years. And the themes really haven't changed. The older they get, there's been more challenges, and disclosure still is a major theme. PTSD, being able to look at that. So those who have more people, they have people in their lives that they can disclose to, have the lowest levels. So being able to have a life that's their life, nothing to do with HIV, is great. As long as you still have people in your life that you can talk to, that know your situation, that know your history, so that you're not denying that part of yourself. Still distress. For the BSI, they call it caseness. There's still distress is there. Probably most importantly is finding a sense of purpose and meaning. The people who've done the best, they have a sense that they're living for something. Here was a great one. Dear disease, I realize the purpose of every living thing is to survive. You're just following the laws of nature. I've given you a good home for 16 years. Now it is time for you to move on. Different ways. And then mandalas, as they get older, change as well. So you could see where they're trying to balance. Part of the life may be HIV, part of the life is something else, or the web, where I may have thought that I may have died, and now I could be able to look at the future, though I'm still not sure what the future will be, to explore both of those, or the path to my existence for somebody who's really is existential. And here, there's a group called Hope's Voice. I don't know if anyone's familiar with that. They have services for young adults who are living with HIV, and they go around and they speak, and two of our pediatric patients decided they really wanted to get involved in that, and they have a campaign called Does HIV Look Like Me? And I'm not going to have a lot of time to go through this, so just let you listen a minute or two.
When I was told about my HIV in the mid-'80s, I was told not to tell anyone for fear of rejection. By the age of 9, I started telling people. Started talking at schools so I could share my story with others. Because I've been living with HIV for most of my life, I'd like to think my dream stayed the same. I still want to finish school, college, finishing up graduate school, live life to the fullest, stay in good health, have a family, get married, have children, same as everyone else. HIV is not to be seen as a death sentence. It's just something to give you an opportunity to look at life differently. Dating's never easy. You meet someone that you like, you fall in love with them, or you fall in love with something about them, and then you're scared about how to tell them about that side of your life. I feel that if I wait too long, people think that I'm not telling the truth. If I tell them too soon, then they don't get to see me for who I am as a person, and not see me as a label, just HIV.
Not everyone has the ability or has the luxury to be able to be public, but sometimes hearing somebody else's story is very helpful. And what's happened for both of those is that you see the curve over here. Early in the epidemic, many of the children died at the young age. You see the age at the bottom, before the age of, early on, before the age of like 9. And then there were peaks a little bit later, but the peak is going back up now for those who were born with the disease or transfused really early in life. And both of them have lost a bunch of friends in the last 2 months. Constant calls. How do we be able to deal with this? And it just takes on a whole new meaning. What it looked like when you're losing friends when you're younger, and now that you've lived this long. And so, how do you be able to help them? And I go back to the artwork, and I give you developmentally. This is a typical drawing of a very young child. I'm an acorn. I am scared of squirrels, and I'm not scared of dying because I'll grow back up again. People's spiritual beliefs and cultural beliefs that they work with families with. This is a preteen who had God's castle in the gold palace. I was a little concerned about this elevator over here. It was a good thing I had a chaplain to be able to work with me with that, because it was a little concerning. But here you have, what do you see in this picture? What is the thing that stands out the most? Person on the wall. What else? Friends. For me, it was the time and energy that went into building the wall. All the energy went into building that wall. So it's blocking. What is this blocking? It's like I flip into my own friends having a good time, but what is that really blocking? And it was blocking tremendous anxiety or an uncertainty. Where do I really belong? I know more people probably through all this experience that are going to be in heaven or where they believe happens next than they are here. But if I'm here, how do I invest in being here? Or survivor guilt. Why am I okay when they're not? If they lost parents, why are my parents okay and I'm not? Going back to the poetry, here was a young lady who was 20 who wrote this, and she was very sick at the time. Take a sip of joy and mix it with laughter. This is the recipe for gratitude to my friends who are still here for me. When I think of blue, I think of the skies and the ones I've lost. When I think of yellow, I think of flowers in bloom and the friends who are still here. I'm abundantly grateful for everything, including the good or bad. And for people just to be able to feel they can say thank you. They can feel like they've made a difference. And it wasn't long after that when she, too, had died, but was very proud of the fact that she was able to make a difference and to be able to leave things that she's written or words to different people. So in the absence of a cure, we could be able to say, yeah, just don't think about the fact that that you could die because you're alive and you're here and there are really good treatments. That doesn't work when you're going to close your eyes at night and just think, but what if this and what if that? And, so being where they're at and being able to recognize that's a concern. So you plan for and you think about the worst case scenario, you plan for that, and then you take your energy and you invest in living. So a study we have going on right now, because I've heard this issue from children and young adults for so many years, is the creation or the possible creation of an advanced planning guide. We took an existing guide called 5 Wishes. Are people familiar with 5 Wishes? And we had the first 20 patients be able to go through the 5 wishes, not to answer it for themselves, but to go through each question. Is this wish appropriate for somebody your age? Is it not? Is it helpful for somebody your age? Is it not? What would you change? What would you take out? What would you put in? And then we had focus groups where kids came up with a whole bunch of other stuff. And so we had the first 20 go through the questions from the focus group and to see what they agreed with and what they didn't agree with. And this is all in your handout over there. And we then created a new guide. And so that new guide is now the next 40 patients are going through that. We've enrolled about 12 so far into that next phase where they compare the new guide with the existing 5 wishes. And again, going through each of the items in there. How helpful is that to somebody your age? How appropriate is it for someone your age? Would you use this? What would you change? What would you add? What would you take away? How stressful would it be to answer each particular question? And for the first phase, just to let you know that people have found the 95% to be very helpful. like 5 wishes, but they had a lot of suggestions of things they would change, and 90% found that it would be helpful to others. No one found that to be very stressful. I can tell you so far for the 12 that come in, they're finding it. Maybe it's more comparing, actually, to it feels a little bit more real. They're finding many of these issues more stressful, but still exceptionally useful. And I think we could walk away feeling that this may be an appropriate tool. And again, it's something that you could be able to do. You could revise it. You could throw it away. You could do it again later. But when you're thinking about what ifs, you're addressing that and then taking your energy and moving it towards living. So I just told you that's what the cover is, when you're asking them the colors and how you want that it to be. So they're very insightful. And people come in, no, don't ask that. And some people just want open pages, and some people don't, and got a lot of feelings about spirituality. And the really most important part is that they're really not as interested in who should make medical decisions for them. They're much more interested in how they're going to be remembered, and how they would want people to remember them on their birthday, or things that who they would want to be able to be with them, or where they would want to be, or who they would want to have some of their belongings. So, again, it's moving on. We know transition as you're moving to adult years, even for those of us who have children who are going to have to leave pediatricians, it's a time of transition. It's not always so easy to move into the adult world, but it's especially so for those with adolescents with complex medical issues. So in 2004, a decision was made to close out our treatment program. So as I said earlier, we probably did a little too well in terms of being able to make these drugs available. But people didn't need to come to us anymore. They can get these drugs in their home communities, and your tax dollars goes to be able to find new treatments. But it was an opportunity for us to say, well, how do we transition these people back to their home to study transition readiness? Some of them had good care at home, but there were 51 families that still did not. And so we looked to the literature on what makes transition difficult, and we created a transition readiness scale. And we administered this with an anxiety and depression scale, so 2 time points. And we assessed what are the barriers for you to be able to feel more ready. And at the first time, a third reported poor to moderate readiness, 30% scored above the clinical cutoff for anxiety, and no surprise, those who were more anxious were also less ready to transition. So the different barriers that we found is not having a physician, having confidence in the physician, not having insurance, having to pay out-of-pocket fees, out-of-pocket of where they're going to get the money to do that. I don't have a social worker or a case manager at home. I don't even have really the knowledge that I need because I think things have been taken care of for me. And so you could see by the time, too, we knew where to be able to intervene. Was it perfect? No. But it was much better. And by the second 6 months later, all reported they had good to excellent readiness. And there was still a lot of anxiety, but no longer related to the actual transition. And the program officially closed in October of 2005. So in this past November, the Academy of Psychosomatic Medicine asked me to present on transition to adult care. So I said, here's an opportunity to be able to go back and see all those people we transitioned, plus there were a whole bunch that were still on some of my psychosocial studies when the program closed. So we designed a study to be able to look at these youth, to contact them by phone, though we do have a longitudinal natural history study, so about 25 still come back twice a year for that. They just send emails all the time, so that's why I'm still connected. And it's never about HIV, by the way. So we went and we looked at, health status, and we asked them about the transition experience, if they're in adult care. We asked them about taking their meds. And again, it was a mixed methodology. So what do those kids look like now? So they're average 20 years old. The majority are relatively healthy in terms of their CD4 counts. 86% are single, 16% have a biological child, 55% have lost their biological mom. The 24% are neither working or in school. 34% have been hospitalized since the program closed, so 2005, but a third of those were psychiatric hospitalizations. So less are on psychotropic medications, but good news is that 93% are receiving HIV care, although a good number said they still struggle with taking their meds. And 71% actually transitioned to adult care. The qualitative piece, which was so rich, tell us what would make it easier to transition to adult care. Logistics, I just need to be prepared for all this paperwork. I just wasn't prepared for that. Or have a program, it could be doctors that could be a little more personal, intimate. If they would just call me by my name, or the changing each time they go, there may be a different doctor, and how disconcerting that could be. Improve communication to be able to have the pediatric people to be able to talk to the adult people. Acknowledge I may be an adult now, but I sure don't feel like one, and don't treat me like I know everything already. It's just give me a little more time to be able to get there. They also like to be able to know they could have more than one visit, that they can go back and forth before they're really ready to make the final transition. Sometimes, for some of these patients, they're in clinics with adults who've acquired the disease in different ways and feel like the staff doesn't really understand all they've been through already, and the fact that they've lost so many people, including their parents. So, wanting them to be able to feel comfortable talking to another adult if they don't get it all right away. So the recommendations is that every single program should have an infrastructure to start working on transition from early adolescence, to be able to assess readiness. So it's not a shock, it's not a surprise, and so it is something they could work towards, and it could be very gradual. And it is really the role of the pediatric provider to assess the readiness, to help foster autonomy, to ensure care providers are identified and records can be transferred. The adult provider should recognize that a successful transition will require care that's personal and flexible. And we really need to have a commitment for the merit of transition by providers on both the pediatric and adult team. So this music's not bad, huh? It's not coming from mine. What is the global picture today? Approximately 2 million children are living with HIV and AIDS. The disease continues to disproportionately affect minorities. 71% of children are still African American. In 2007, children were infected at a rate of 1,000 a day globally. And although there's been large-scale efforts by the United States and the UN and many other various international organizations have made critical progress, not all the places are receiving the care they need to. We still need to move to a world closer to a generation that could be free of this disease. We are definitely not there yet, because the majority of the cases are preventable with tools that exist, but the pandemic continues to claim the lives of millions. And domestically, I don't know if you read what was going on in Washington, D.C., but the numbers are really concerning because infections are on the rise. We can't give up. We can't stop. We have to continue to advocate and to continue to teach and continue to get the funds, even if the numbers are lower, to stop this disease. So where do we go from here? Prevention, screening, support. Have a relationship. Deal with disclosure. Deal with losses. Have mental health follow-up. I'd like to have, healthy checkups. You have your healthy checkup for your medical. You should have a healthy mental health checkup yearly. It should be part of it. It should be a part of the same team. I could yell about this forever if people don't listen, though. Insurance companies don't like it, but I'm not going to stop yelling about it. Vocational assessments. Especially if you've had the CNS involvement when you were younger, you may not be able to do the things that you've wanted to be able to do. So you may not have the skills. So to get vocational assessments early on so that these youngsters can have skills they could actually do and feel a sense of purpose. The ones who do best have a sense of purpose. Advanced care planning, as we just talked about. Transition, start early. Make sure they can transition to adult programs and get really good care. Reproductive planning. I can't tell you how much this is a huge issue. And that little baby, by the way, is Tanya's. She stopped saying no, no, no. And finding a sense of purpose. So I'm going to leave you with the messages I find to be the most important, although we could leave this. And I practiced this with two of my students who told me, they're not going to know what you're talking about. We weren't born then. And they said I should ask you what the most important lessons are at the end. But for me, the greatest fear is being forgotten. And here's a letter one mom left to put in the chart after her son died. And I thought this was magnificent. To the future, if you are reading this chart, I just want you to know something about my son. As you could tell from his chart, the course of his illness was long, hard, in a word, complicated. But what you can't know is what was most important. How brave and noble his fight for life was fought. The way he loved balloons and other children. He laughed and smiled until the last day he was off the vent. If you ever doubt the intrinsic goodness of your fellow man, if war or madness ever make you wonder why you are in medicine, you could chant his name like a mantra. Goodness shines in the eyes of all children, and beauty of soul and spirit that shine from his eyes gives me the strength to go on without him. I love you, And in an odd way, I love you who read this as well. It is because you are a part of a chain of people who will give meaning to my son's suffering. Cure this horrible disease with respect and grief. Sense of not being forgotten, making a difference. The next lesson is that it doesn't matter, I may have been talking about HIV and AIDS today. It's more important to know what sort of patient has a disease than what sort of disease a patient has. Everything I said can be applicable to whoever it is that you're working with. And many individuals have, like cut diamond, shining qualities beneath a rough exterior. We work with some really difficult people. And I give you the example now of a father who was in and out of the crack house, and he did a lot of things that made his family and the staff. Can't tell you how many times my people went off because of what he was doing this particular day. But he would sit in a clinic and draw. And so one day I just said, can I see what you're drawing? And he said, no, I don't know, maybe tomorrow. And I said, all right, but what I want you to be able to show me is what's going on for you and what you think is going on with your family. Anything you do, just help me see it through your drawing. So he brings that in the next day. And a few days later, he said, you really want to know what's going on? It's that. So what the future's going to bring, and the fact that he just couldn't really deal with that. And he did go back out to the crack houses, and he was in and out. But about 2 months later, he sent me this in the mail, rolled up in a little scroll. And I'd like to leave you with that. Lord, grant us with the strength, courage, and patience to make it through another day. Grant us with enough love to help our children make it through another day, and enough understanding to be able to reach out and help others make it through another day until we pass or a cure is found. Amen. So this part of the talk I dedicate to the NIH experience and to those who I thank and pay tribute to for sharing their thoughts and their stories with me and allowing me to be able to share them with you, and to those who will be with us forever, but who also shared their words, their vision, their love with you, and now me to you. Thank you. I do have one more slide because people always ask me at the end, how do you do this? So I have to just show you this one slide. Excuse me, but aren't you in the wrong clinic? Wrong? Why would this be wrong? You women think you're the only ones with problems? I get hysterical too. I get hot under the collar. I get panic attacks. I get cramps. I hate my life. Wait, don't you want to see the doctor? I am the doctor. Thank you, guys.